Good evening all. I take this opportunity to welcome you all for the second webinar of IAPA. So we have with us Professor Srinath Reddy, the Doyen of Public Health in India. Thanks a lot, sir, for sparing your valuable time amidst your busy schedule. And I also take this opportunity to welcome Dr. Kunal Sarkar, Chief Cardiac Surgeon of Medica Super Speciality Hospitals, Kolkata. A hearty welcome to you also, sir. And I also take this opportunity to welcome all the physician assistants from across the world and PA educators who have taken their time off to join this session.
Kindly allow me to introduce Dr. Kunal Sarkar, Senior Vice Chairman, Chief Cardiac Surgeon, Medica Super Speciality Hospital, Kolkata. He is the past president of IACTS and also a member of many prestigious cardiac surgery associations. He has got trained in general and cardiac surgery from UK from 1986 to 1996. He is practicing CVTS surgery in Calcutta since 1997. He specializes himself in adult cardiac surgery. So far performed close to 25,000 cardiac surgeries. He has pioneered in beating heart surgery and surgery of heart failure. He also has strong passion for public speaking with interest in history, politics, and socialism. May I request Dr. Kunal Sarkar to inaugurate the session with inaugural address.
Thank you, Shiva Prakash. Thank you, Shiva Kumar. And thank you for having me this evening. First of all, I think it's flattering and it is humbling to be in the presence of Dr. Srinath Reddy, because many moons ago, when we returned to this country, it was the teachings and lectures of one cardiologist which kept us mesmerized. And that is a cardiologist who would not speak about guide wires and stents, right? So there were so many lectures we attended. We literally, there was a time when I would literally seek out that where Dr. Reddy would be speaking and his thoughts about the principles of cardiological treatment in the community, about medical cardiology, the practice of minimizing cardiac mortality, morbidity, improving outcomes throughout the country. I think it was an eye-opener for us. And, I can definitely recall at the back of my hand at least 10 of his lectures I've been to. And in each of these sessions have been a tremendous learning opportunity for not only of me, but I think people of my generation and beyond. So, Shiva Kumar, I compliment that you are lucky you've got Dr. Reddy with you this evening, and people like myself should not eat into the valuable time that he will be spending with us. And being from Calcutta, sir, if I'm not mistaken, I think you do have some linkages to this part of the world, because probably your esteemed father was the erstwhile governor of our state, right? Is that correct, sir? Right?
That's right, sir.
Yes. So, and those were better times, those were the days when people were not fighting with one another like cats and dogs. So, look, whoever good you find in the world is one way or the other connected to Bengal, right? So, probably with the exception of myself. So, I think, I'm as keen as all of you to listen and learn from Dr. Reddy. And, sir, I think, please guide us, educate us. And you are, I tell you, there have been many an occasion where I have been amongst these very keen young people, the physician assistants. And I'm sure there is no point in preaching to the choir. But these young men and women, they literally form the spine of cardiac services in the country at the moment. Many an unit which looks very prominent, doing good work, but they are the core of the unit. And with their dedication and their competence, I think they've been absolutely exemplary in what they have done so far. So I think with your wisdom and with your guidance, they will do even better. So Shiva Kumar, I think there is nothing to introduce Dr. Srinath Reddy, but perhaps you would like to formally introduce him. But I'm just as impatient as the rest of you are to listen to him.
Thank you very much, sir. May I request Ms. Anika Chandrasekhar, Senior Vice President IAPA, to introduce the speaker?
Dr. Sarkar, it is indeed our proud privilege for you to be present here to inaugurate this session with Dr. Srinath Reddy. You always have very kind and encouraging words for us, and we are ever grateful to you for the kind of love and encouragement you've shown for us. May it be for people working with you and for those who are not even working with you, you always have encouraging words. Thank you, sir. Professor Srinath Reddy, I've been asked to introduce him. He is a public figure who needs no introduction, certainly. He is, as you all know, is the president of the Public Health Foundation of India. If I have to start listing his achievements, I would probably be consuming the entire duration of this webinar. But I will just highlight some few very illustrious points in his great career. So Professor Srinath Reddy was formerly heading the Department of Cardiology at the All India Institute of Medical Sciences. Under his leadership, PHFI established 5 Indian Institutes of Public Health in different regions of India to advance multidisciplinary public health technology and implementation support for strengthening health systems. He was appointed as the first Bernard Lawn Visiting Professor of Cardiovascular Health at the Harvard School of Public Health between the years 2009 and 13, and he presently serves as an adjunct professor of epidemiology at Harvard. He holds advisory positions in several national and international bodies, and recently published a book named Make Health in India Reaching a Billion Plus. He is also an adjunct professor of the Rollins School of Public Health, Emory University, and honorary professor of medicine at the University of Sydney. He's the first Indian to be elected to the National Academy of Medicine in the United States and was awarded several prestigious international and national doctorates and fellowships. He is a Padma Bhushan awardee, and in this recent ongoing pandemic, Professor Reddy is a member of the Government of India Technical Task Force for COVID-19. He's also an advisor to the governments of Odisha, Punjab, and Andhra Pradesh on public health. Apart from all of this, my dear friends and colleagues, Professor Reddy has been a great patron and connoisseur for the PA profession. He has been an integral, instrumental in getting ourselves enrolled with the Ministry of Health, Allied Health Sciences, and he has, attended our annual conference. He has written extensively about us in his newspaper columns. He's always been a person who has pushed us to make ourselves known to others, to increase public awareness of physician assistants. So it is indeed our proud privilege to have him for the second IAPA live webinar. And most of all, my dear friends, he is such a simple, humble, down-to-earth, wonderful human being, and there is so much to learn from him, from the way he conducts. So eager to listen to him today. Over to you, Prakash.
Thank you. Now may I request Dr. Srinath Reddy sir to present the.
Okay, thank you very much. Well, I'm already humbled even more by the wonderful introduction given to me and the very kind remarks of Dr. Kunal Sarkar. Very kind of you, sir, to have made such remarks. And thank you very much for this opportunity and invitation to interact with the community of physician assistants of India, but also I understand some international colleagues have joined. I think it's absolutely very critical that we really look at India's health system as well as the global health challenges that COVID-19 has actually brought before us. Interesting historically that the professions of nurse practitioners and physician assistants were actually born out of the experience of a world war and the Korean War. And then the great value provided by these categories, which were still incipient, led to the creation of formal categories of allied health professionals who could actually take over several of the functions traditionally performed by doctors, but which now could be performed with great skill and competence as well as commitment by these categories of providers. In terms of physician assistants, I think in India, we have seen physician assistants emerging, particularly to support services in tertiary care hospitals, particularly in the area of advanced care, as Dr. Kunal Sarkar has very clearly pointed out. And cardiac surgery services in particular have benefited greatly, but other tertiary care services have benefited as well in hospitals. But when physician assistants were originally conceived, and even for the mandate that have been adopted within India by the physician assistants in an aspirational mode, clearly primary healthcare fits in very pivotally over there. And I believe it is in primary healthcare that we will require physician assistants to now emerge as a major contributing force in India and elsewhere too. And the reasons are very clear that we are going to be facing a huge challenge of providing services in primary healthcare. And let me give India as the case study. And then I'm sure there are global examples which can also be recounted, which will reflect the same reality of health systems in many low and middle income countries, but also even in advanced economies where primary health care has been neglected and continuity of care between different levels of health services has also been neglected. We are obviously facing multiple healthcare challenges now, but even when we look at COVID-19, it is very clear that much of the care and much of the response, even in terms of public health, needs to be given at the level of primary health care. For example, who are the people to be tested? How do we detect people early for testing without waiting for them to declare themselves for testing at an advanced state of disease? How do we actually do household surveillance on the basis of symptoms, what we call syndromic surveillance? How do we actually look at people with influenza-like illness or COVID symptomatology, which can be either fever, cough, and breathlessness, or some of the other symptoms which are now also known to be associated with COVID? How do we detect such people early and refer them for very early testing? How do we ensure that those who are found positive and asked to isolate at home are provided the appropriate care at home? Like, for example, in Delhi, now many of the people with mild symptoms are being advised to take care at home. So how do we actually ensure that their temperature and oxygen saturation with pulse oximetry are being checked? And there is no reason why blood pressure also can't be checked if it's an important comorbidity. How do we ensure very effective contact tracing? All of these, how do we ensure that there is early detection of the need to transfer to a hospital if the symptoms or the clinical condition is deteriorating, and how do we arrange for that kind of a transport and admission? So the linkage between effective community-based primary healthcare services and hospital services is so integral, even in the area of COVID, where initially the attention was all on advanced care and ventilators. And now we are recognizing that all the elements of a good health system at primary, secondary, and tertiary care need to be protected and promoted. For example, we also now recognize that very few people actually require ventilators. Many of them can do well on oxygen, even if they have respiratory distress. And how do we equip our district hospitals and other general hospitals with that kind of an oxygen flow capacity, which is consistently available, rather than just depending upon a few top-notch hospitals? So every single layer of our health system at every level has to be strengthened in terms of capacity and competence if we have to face a public health emergency like COVID. But coming back to even who are the people worst affected by COVID, we recognize that it is people who are not only at the advanced age, but also people with comorbidities, whether it is the elderly with comorbidities who do worse than elderly without comorbidities, or even middle-aged persons with comorbidities who do badly. So there, the whole question of how do we actually early detect high blood pressure and diabetes and respiratory disease, and how do we actually manage them in different settings of healthcare so that these people are not badly affected. How do we prevent them in the first place? How do we ensure that the vascular damage due to diabetes and hypertension does not get aggravated because of late detection and poor management? So all of these actually then come back to primary healthcare and very effective primary healthcare at that. But even in terms of hospital care, how do we actually ensure that there are no missed opportunities and lapses which reduce the effectiveness and timeliness of treatment? So we do require a much more augmented health workforce, and we are very short of that health workforce at every level of care. And the World Health Organization at the time of the Millennium Development Goals in 2000, because their focus was mainly on maternal and child health and infectious diseases, and to some extent on nutritional deficiencies, said that a competent health system must have 23 health workers for 10,000 people. And said if you have less than that, you're going to be failing in delivering adequate health services. But remember, these were only geared towards the Millennium Development Goals. It was not a complete response. Non-communicable diseases, cardiovascular disease, mental health, respiratory disease, cancers, they were all left out. Mental health was left out. Many other conditions which were part of the non-communicable disease spectrum, whether it is kidney disease or liver disease, gastrointestinal disorders, all of them were left out. So when the Sustainable Development Goals were framed in 2015, the WHO again looked at what is the mandate of the SDGs. Not only the expanded health mandate in terms of multiple conditions, including NCDs, non-communicable diseases, and mental health being brought in, but also universal health coverage being brought in very clearly. And if you have to deliver universal health coverage as an important element of SDGs, and now even of our National Health Policy of 2017, you do require a multi-layered, multi-skilled, highly motivated health workforce. And therefore, the WHO recommended that 23 per 10,000 is no longer a sufficient number. You require actually 44 per 10,000. In fact, that is the revised number that they came up with. Now, we are very short of that number. We were short even of 23, and we were very short of 44. There are some states in which you can say, okay, we have reached 22 or 23, or maybe a little more in some cases. But if you take the all India figure, our figures are low. And there is a huge asymmetry of distribution of the health workforce across this country. There's no point in having adequate number of health workers in Kerala or Tamil Nadu if much of central India, northern India, northeastern India have very low levels of health workers. So whether in terms of delivering health services and meeting the health targets of the Sustainable Development Goals, or for delivering universal health coverage, we are going to require a much larger health workforce with multiple cadres and competencies. And that is where I believe physician assistants will have to play a very critical role in primary health care as well as in hospital health care at different levels. And that recognition was not previously there. Many people, I'm sorry to say, in the health ministry or in even senior levels of health policy making were not even aware of the existence of physician assistants till a couple of years ago. I know that physician assistants have been working in hospitals, particularly in tertiary care hospitals, and have been remarkably effective in providing very competent care. But the fact that such training opportunities are there in India and that these cadres can be very useful at various levels of healthcare was not clearly recognized by the policymakers. It is only when the bill was being made for allied health professionals that advocacy by people like Dr. Shiv Kumar and others, supported to some extent from outside by me, brought this to greater attention, and I'm glad to say, at least now the physician assistants have been recognized as a very valuable cadre. And we do recognize that our mandate now is to provide comprehensive primary health care with continuity of care and also linkages with higher levels of care. So our mandate will require much larger health workforce with greater portfolio of competencies at the level of the sub-centers, at the level of primary health care and community health centers, at the level of the district hospital, at the level of the medical college hospital, and elsewhere. So far, it is only the private sector that has recognized the value of physician assistants and has been utilizing them in some places. But we require also for the public system, very much so. There is a great need to strengthen the public healthcare system. And even as the healthcare sector expands across the country, particularly to fill the gaps that exist in large parts of the country, the physician assistants can be a very, very important resource under CADA. And the nature of their competencies equips them to do that. Therefore, I would suggest that we ought to be really looking at how best we can strengthen primary health care with an array of non-physician healthcare providers, particularly the so-called mid-level healthcare providers, where they're trying to develop nurse practitioners. But again, we have also had shortage of nurses, but physician assistants can come in very well over there. They can even come in at other levels of primary health care at the district hospitals and the medical college hospitals. I think there is a great opportunity. Now there is a greater commitment in order to expand the health workforce and to put more money into the health sector. Not only the central government is talking about it, but the 15th Finance Commission appointed a high-level expert group. It was a group convened by Dr. Randeep Guleria from All India Institute of Medical Sciences, and I happen to be a member of that 6-member committee. And I must say, even before COVID-19 came in, we made a strong case to the 15th Finance Commission that health has been grossly neglected in India, with barely 1.2% of the GDP being spent on health, and a great variation in the state budgets. And we need to actually spend more in terms of public financing and ensure that our health workforce expansion, hospital infrastructure strengthening, as well as availability of drugs and diagnostics, all of these issues, and of course, strengthening our health information systems, all of these are absolutely essential if we want to deliver upon the promises of the National Health Policy of 2017, our commitment to deliver the SDG targets by 2030, and particularly provide universal health coverage. So this is now being revisited again. The Finance Commission had decided that they are going to make a strong recommendation, and particularly health workforce is going to be a very important element of their recommendation. That happened even before the COVID-19. Now they convened another meeting about 6 weeks ago in order to find out how we can even further revise the recommendations, and a new report is also going out to them. But the heartening feature is that the Finance Commission, which actually directs how the tax revenue should be divided between the center and the states, is now planning to recommend higher allocations for health, both at the central level and at the state level, with a greater emphasis on 2 elements, which is strengthening primary health care and district hospitals, as well as expanding the health workforce. And the cadre of physician assistants also figure in those discussions. So there is a great opportunity now to utilize the interest that is coming up in the political and decision-maker circles as to how best we can strengthen our health system, not only to meet public health emergencies, but also all our other health services. Because we have repeatedly reminded them, and we must remind ourselves as well, that a weak health system cannot suddenly create a surge capacity overnight when challenged with a public health emergency. It has to be functioning with efficiency and equity even during the steady state, if it has to be capable of generating with speed and successful response capacity when challenged with any type of public health emergency. So we have to fill in all the weaknesses that we have identified now in our health system, which have been exposed even by COVID. Because what COVID has shown us is, if you're only focusing on COVID-19, then you're neglecting all other health problems also in the community. You're not looking after your antenatal care, you're not looking after your institutional deliveries, you're not looking after your child immunization, you're not looking after management of high blood pressure, diabetes, and mental health problems in the community or even in hospital settings. Many elective surgeries are being postponed. So you have to have a health system which is capable of dealing with all of these challenges, plus an emergency. You can't have a health system which is hopping all the time on one leg and expect it to race when a public health emergency comes in. So those are the lessons that are being absorbed by the decision makers, being highlighted by the media, and usually during an emergency, when it passes off in 10-15 days, people forget the lessons. But this is getting a protracted emergency. COVID-19, bad as it is offering the opportunity for us to keep the limelight focused on the health system and the need to strengthen it. And physician healthcare providers can play a particularly strong role in that area by showing how at different levels of healthcare, with competencies that can address the different needs and requirements at primary healthcare, district hospital level, or medical college hospital, they can actually fit in very well. And particularly at the level of health and wellness centers, which requires not only a certain degree of clinical competencies, but also a public health awareness and managerial competencies. Your training programs should now equip you to take leadership roles in primary healthcare and deliver both in rural as well as in urban primary healthcare. That's going to be important. There is one other element that is coming up. That is the National Digital Health Mission, which has just been launched on August 15th. Now, the National Digital Health Mission has both horizontal as well as vertical packages in which you need to gather data, analyze data, link up data, and there are three critical elements in that. One is continuity of care, because that is what is required in health. A patient should be able to have continuity of care from a care provider who is aware of the past history, past investigations, past diagnosis, past interventions. Otherwise, every time if a chapter has to be opened afresh again, then it's going to be wasteful and sometimes can have dangerous delays. Secondly, you need to have connectivity of care between different levels of care and at each level of care, between primary, secondary, and tertiary, and all the way back again from tertiary to secondary and primary as needed. Secondly, if, for example, even at the level of tertiary care, a diabetologist wants to refer to a cardiologist, again, the records should be available for sharing. And at the same time, you need portability of care. If somebody from one state moves across the country to another state, there should be easy accessibility of those records. These records are not easy to maintain, not even easy to assemble. Of course, we need to make them as less complicated as possible, not as laborious as in the US, where a litigant society leads to defensive medicine and very complicated recording. But at least even in terms of simplified records, it requires a certain degree of skill and a certain degree of integrity in recording the data and maintaining it. Now, unfortunately, because of our hospital conditions or even in primary healthcare conditions, doctors feel that they cannot do it because they say, do we look after patients or do we turn to the computer and maintain the records? I believe here a digitally savvy physician assistant can not only provide a lot of support in clinical care, but can take over a good deal of the functions of digitally recording all of the medical records, assembling them, and preparing them for the digital storage and transport to suitable destinations. So I think there is a lot of opportunity where you can now demonstrate your skills and you will become indispensable in the new medical architecture, new healthcare architecture that is emerging in this country. So these opportunities you'll have to utilize through the nature of your training. Secondly, there are also soft skills that must be developed. Now you can find a lot of confrontation going on between doctors and patients. Doctors are getting beaten up. Nurses are sometimes being assaulted by irate and angry patients, attendants, and families. That is because there are deficiencies partly in the way hospitals are run, overcrowded. The healthcare providers are under great stress. The expectations of the patients, particularly when they're brought in at a very late stage because of neglect in primary healthcare, their expectations of lives being saved is very high. And if they're disappointed or in a crowded hospital, attention is delayed, then there are frayed tempers on both sides and there is a fair amount of violence. Now, where does the empathy factor come in? Empathy should be built into all levels of healthcare providers. But a good physician assistant who is supporting the doctors should also be able to talk, to explain, to communicate, to allay the anxiety, and should be the effective bridge between the doctors who may be otherwise too busy to explain and the patient and the patient's relatives who are waiting for some comforting word. So there are soft skills also to be developed. So whether it is computer skills or other diagnostic technologies which are emerging, or there are many other areas of clinical care that are emerging, or even in terms of communication skills, there are lots of things that the physician assistants can actually acquire and also utilize effectively. So I believe that as we move towards a more expanded health workforce with a larger health agenda of healthcare and prevention at all levels of healthcare, and focus particularly on continuity of care, and when many of our non-communicable diseases will be demanding chronic care, physician assistants will have a tremendous role to play in that scenario. But you must now become more visible. You must ensure that as the bill that is before Parliament is passed and the allied and the healthcare professionals, healthcare providers or healthcare professionals bill becomes an act, you must seize all the opportunities and try and have more training centers so that there are more physician assistants produced in this country. And you must flood the health system with your expertise and show how you can transform healthcare at all levels in this country and deliver to the people of this country the kind of healthcare that they desire and deserve. Thank you very much.
Thank you very much, sir, for the enlightening speech. Now, may I request Mr. Somu Chatterjee, Associate Professor, University of Kentucky, to share his views on.
Are you all able to hear me?
Yeah.
Well, thank you. Thank you for the opportunity. So thank you, Dr. Reddy and Dr. Sarkar. Nice to see you again. How are you, sir? Sorry, can't hear you. So, Dr. Reddy, it was really enlightening and very heartening to see you talk about the challenges and the scope of involvement of physician assistants in India. So my background is, I've served many years in India in the primary healthcare as well. I was 5 years in the army in India, and currently I'm an associate professor at the University of Kentucky, teaching the PAs. So going back to, the point that you made, there is a national push towards figuring out, how to utilize the PAs in India. How do you think we can build a consensus in India between various organizations so that we can make this a possibility?
Well, I think firstly, the shroud of invisibility that was there has been mostly removed now. And once the bill becomes an act, there should be a greater awareness built in. As I said, many of the people in the policy circles in the media were not even aware that the category of physician assistant exists in India, what kind of a role they can play, and what kind of training is provided to them in those 4 years of training. So I think we must really keep talking about this so that more people recognize it. And particularly if people are leading in the medical profession can talk about this at various fora, people will listen. Fortunately, now the health ministry and some of the other decision makers in the Niti Aayog are convinced. But we need to convince more people, particularly at the level of the state governments. Then we must also ensure that there are more institutions training people. So we must explore all of those opportunities. Particularly now, district hospitals are going to be converted into medical college affiliated hospitals in many parts of the country, particularly in those states where there are very few medical colleges. So the idea is to try and convert as many district hospitals into medical college affiliated hospitals, to build new medical colleges around them. That is where we can get allied health professionals also trained in larger numbers, and physician assistants should be at the forefront of that. We are never going to be able to fill in a short period of time, even in the district hospitals, and the required number of people who can provide clinical care. So physician assistants being trained there and also being employed there is a strong possibility. So we must look at all of these opportunities, but I think getting to the state health secretaries is going to be the next step. At the central government, there is awareness and there is some conviction, but approaching the states is going to be the next big step that is required.
Yeah, thank you for that response. Dr. Sarkar, you wanted to say something?
I just wanted to, ask Dr. Reddy and take the opinion of Shivakumar and his colleagues. That, there is a tendency, Shivakumar, that whenever we have conceived of a physician assistant role so far, it tends to be very typified into a tertiary hospital, OT assistant, etc., etc. But from what Dr. Reddy said, I'm sure you were aware of it before, even in last year's meeting in Mumbai, that now the role has to widen up and spread across the whole spectrum, from primary to tertiary care. So is the training system, is the way we are producing the physician assistants, is that synced with this necessity?
Sir, that's a big challenge right now, because at this point in time, the training is not in sync with what is actually required. So that is the reason why we are trying to sensitize people across the spectrum. Like we have academicians, senior physician assistants, policy makers, healthcare professionals. So everybody should be in sync. And we have actually submitted a draft curriculum to the ministry. So that curriculum actually is basically in sync with what is actually required.
Shivakumar, I think along with that, I think the sooner we recognize different types of physician assistant, I don't know what Dr. Reddy thinks about it, because you cannot be an undefined heterogeneous mass like this. That is not going to address the vision that Dr. Reddy is giving us, because otherwise there will be lots of apples and oranges in the near future. So I think you need to rediscover, reinvent the thing and do it quickly. Otherwise you'll be out of track with time.
Sure, sir.
I fully agree with you, sir. I fully agree with you that even during the course of the training, some degree of the definition of specific competencies will have to be there. And we may be able to do that at the district hospital level, but certainly at the sub-district level, they should be exposed to primary health care, and at the tertiary linkage, they can be exposed to tertiary care in the initial 2 years of their training. But later on, some sort of specialization stream must emerge so that they have the specific competencies.
Sir, actually, this is precisely what we have also recommended to the government. And we are actually looking forward for the bill to be passed and the program to be started up in all the central universities. And parallelly, once the COVID situation normalizes, we are planning to meet all the health secretaries. So first, I will be doing it in Tamil Nadu. Tamil Nadu being the first state, we'll be meeting the health secretary of Tamil Nadu. In fact, he is aware of the PA program. In fact, he was the chief guest for one of the IAPA conferences also, that was way back in 2013. So I'm sure, I'll be able to connect with him at the earliest. And probably with Professor Reddy's support, I think we can also take it up with the health secretaries of Andhra Pradesh as well as Orissa, and then maybe even Assam. That's what I was discussing with Anita also a couple of days back. So our next target should be approaching states like Andhra Pradesh, Assam, and Orissa.
Absolutely, absolutely. And Shivakumar, Sir, Dr. Reddy, I'm being a little bit impolite. I've got to take a leave because the meeting is starting in a couple of minutes. You please carry on in the discussion. And sir, it was such a learning experience as ever. Thank you very much. Thank you for asking.
And Dr. Sangat, thank you so much for your time. And before you leave, one more request from my end. So probably I'll approach you, for a meeting with the Health Secretary of West Bengal.
Please, anytime.
Dr. Sarkar, thank you very much. I must also mention to you that my wife was born in Calcutta.
Oh, look.
Though that doesn't explain my fondness for the Mishti, but your words have been sweeter than Mishti, sir.
Sir, it's been a pleasure. It's been a pleasure. All of you, God bless. Take care. Stay well.
Thank you, sir.
Dr. Reddy, looks like, at a national level, we have identified the gaps and the opportunities that we have for the PAs. But I guess where will the consensus of the roles and the competencies that you talk about, would that be at a central level, or should that be at a state level, or it can be a mix of both, like the first 2 years, common competencies, and then, because every state requirement is different.
That is true. But what would happen is that medical education, dental education, etc., are all under the central government. And I think under the Act, the central government will retain the standard regulation of the various allied health professionals as well. But as the training gets into the state level, the state can redefine some of the requirements as needed and then make changes as appropriate, because the kind of training requirements in Assam is going to be different from the requirements in Bihar or from Kerala. So I think that level of adaptability can be brought in. I think the biggest opportunity for advocacy as well as the biggest resistance is going to be at the level of the doctors. So the doctors will have to be convinced that this is not a threat, but a great support system. So I think that is the other battle that we need to fight.
Yeah, you're absolutely right. I mean, there are opportunities in there too. What we have seen here in the US is actually like in India, there is a challenge retaining individuals or healthcare providers, especially doctors, in the primary healthcare system in rural areas. And what we have found here is when we recruit locally from the area, and when we train them and put them back into the same area, the retention rate has skyrocketed to 70 to 80% now. So I think given the various language and the cultural variety that we have in India, I think that will also be a very good job opportunities for rural India as well, if they can get trained and put back in. The only thing is how to develop a sustainable financial model at a primary healthcare level, which would keep this going.
Yeah, and also some career tracks, because people may not want to be at the sub-center all their life.
Absolutely.
So some sort of further training opportunities and career tracks will have to be built in. Absolutely. I think, I do not know about Shivkumarji, whether you have actually managed to engage with the various vice chancellors of medical universities across the country. Because they're going to be, again, very important for looking at the training issues.
So right now, I am only in touch with Tamil Nadu MGR Medical University Vice Chancellor, and slowly we'll have to reach out to other Vice Chancellors also. Prior to this, I had a very good rapport with the Vice Chancellor of West Bengal University of Health Sciences, Professor Bhavtosh Biswas. Now that he has retired, I have to establish contacts with the new VC also.
Why don't you take the help of those people who are currently still there? Because I believe every year there is a conference of the vice chancellors.
Okay.
If that can be put on the agenda and this can be introduced as an area for training to be introduced in their respective states, that is another way of looking at it. Because even if you go to the health secretaries of the states, they're going to ask for the opinion of two people, the State Director of Medical Services or Director General of Medical Services, and secondly, the Vice Chancellor of the State Medical University. So you have to win them over before you get the bureaucrats to sign off on it.
Sure, sir. I'll certainly find out when this meeting is happening, and I'll get an appointment and probably have a word with the Vice Chancellors also. So I'll definitely do that. And in the meantime, I did meet Dr. Vinod Pal, member of Niti Aayog. So in fact, I had requested him to start the physician assistant programs in all the national medical universities across the country, like AIMS, Jitner, and PGH, and so on. So he also expressed interest, and he has also put in a word to Kavita Narayan, and he has requested her to look into it.
Sure.
And I also had an opportunity to meet Dr. Harshavardhan also last September, and I also emphasized on the need to have a physician assistant as the ideal mid-level healthcare provider. That is the terminology used right now in the NMC. So I had emphasized the need to replace the physician assistant cadre for that role. That mid-level healthcare provider per se has not been clearly defined in the bill. So I said, we are there and we'll be able to fit in. And actually, I would like to also thank Professor Shiv Kumar Chaudhary, because Sir was settling Dr. Shiv Kumar. Actually, I am not Dr. Shiv Kumar, but the original Dr. Shiv Kumar who actually helped this Shiv Kumar is the professor of cardiac surgery in AIMS. So he actually helped me in getting that appointment to meet the Union Health Minister, wherein I was able to emphasize on the need to have this cadre, whenever he thinks of getting this mid-level healthcare professional program up and running. Dr. Vinod Shah from CMC Vellore.
Yes, I've always been very keen that physician assistants should move into the primary health arena, and if there is a problem, we can create two streams. I think you're already doing that. Have a basic course and then have two streams, one for primary health and another one for hospitals. I think it'll be a great benefit because it multiplies the effort of a doctor many times, and actually once they begin to do work, they will be as good as or even better than doctors, because they will continue to be in the same place, and so doing similar kinds of things every day now, so they will become very skilled. And in Vellore here we have physician assistants, and they are extremely useful. So I really feel that somehow if we can expedite this quickly and get it going, it'll be a very great help even for the corona crisis.
Sir, actually, it would be better if we actually start running this program from CMC Vellore also. At this point in time, CMC Vellore conducts a lot of allied healthcare programs in collaboration with Tamil Nadu MGR Medical University. But I think if CMC Vellore can actually get into the scheme of things and start running the PA program, I'm sure there will be greater emphasis on primary care, and it will be a game changer actually.
Actually, the principal is willing to start, but I believe the paperwork is not over. You know, the act and whatever else had to happen, they haven't actually happened. And the university accreditation has to come in. So the principal herself is very keen to do it.
This initiation by IAPA is so nice to recognize, make it more recognized to physician assistants. I too wish all these bills can come soon so that we get a proper recognition for our students and this career develops a lot. So I'll be supporting you in all ways. Our institution will be supporting in all ways for doing this also, sir.
So, Dr. Vaishnav Devi is the professor in charge of physician assistant program from Vinayagar Mission University, Salem. So they have been conducting this program for almost a decade now, and they have effectively utilized the COVID time for academic activities. Almost every month they are conducting a webinar, and they are trying to keep all their students up and running. So that's a very good initiative, which probably I have not seen with most of the other universities. So good luck, Dr. Vaishnav, and we'll definitely be in touch with you. And together with the support of all the academicians, only I think we'll be able to achieve our goal.
Yes, sir. Thank you, sir. This is all done by our dean only, his support only. I'd like to thank him for this enthusiastic support. He is encouraging us to do this work.
Yes, Prasad, please introduce yourself and then share your thoughts, please.
Yeah, I'm Prasad. I'm a senior lecturer in Amrita School of Medicine, Kochi, and coordinator in charge for the PA program in Amrita School of Medicine. It was a very enlightening and very thought-provoking speech by Srinath sir. And I am very thankful to the IAPA for organizing this kind of webinar presentations and connecting everybody in a platform. It was a very, very nice talk.
I take this opportunity to thank Professor Reddy to be in our midst in spite of his very tight schedule. Because as Anita mentioned, he's member of the COVID task force set up by the Government of India. And with Professor Reddy, I always consider him like my father. Whenever I have an issue, I always approach him, and he's always ready to support. And I'm sure he will continue to advise us, and with his guidance we'll be able to reach out. And I'm sure he will also be supporting me in our endeavor to meet up with the health secretaries or vice chancellors of various universities in Assam, Odisha, as well as Andhra Pradesh. So probably, sir, I will certainly be in touch with you, and I'll take your assistance in setting up a meeting with the key people in all these places. And parallelly, I will also ensure that I meet all the vice chancellors of all the medical universities once the COVID situation is over. So I also take this opportunity to thank Dr. Somu Chatterjee, who has taken a lot of interest in taking part in all IAPA activities. I'm sure it's very early morning in the US right now, but still he has taken this time off to support us. And I also thank this opportunity to thank all my PA colleagues, students, academicians like Professor Vaishnav Devi and Dr. Shah from CMC Vellore, and few of my African colleagues. They just texted me that they are unable to join because of some glitches there in Kenya. So otherwise we would have had some African experiences also. But anyways, we did have a very enlightening session from Dr. Reddy, and with Dr. Sarkar at the helm of affairs. We always know how he speaks, and he's a very good orator and a great supporter of the BA program in East India. So thank you all for the time, and again, end this vote of thanks with a special thanks to Professor Reddy. Thank you so much, sir.